I think the other thing we haven't touched on is tolerability of oral SERDs, right?
Yeah.
They seem like a great class of drugs. Can you
Yeah.
speak a little bit to the experience of your patients of being on oral SERDs and
I can.
what's great about it?
I can. So I've had a privilege of having both CAMBRIA 1 and CAMBRIA 2 trials for my patients to enroll onto in Annapolis. And it's great. By and large, one of the most enthusiasms patients would have for going on to the trial was the potential to get off the aromatase inhibitor that was causing them arthralgias. And most of the time I see that patients feel better. Now, what's interesting is that isn't necessarily reflected in the published data. Like, for example, the recently reported Lidera data, where arthralgias were pretty substantial. And again, they're all different agents, right?
Yep.
But what I tend to see is far less arthralgias. And then the more commonly discussed bradycardia, that's asymptomatic and honestly a non-issue. The visual changes are a minority of patients, go away with time. They don't bother the patient. It's not structural eye damage. So really the reality is the experience has been truly actually universally positive.
That's wonderful.
And in my less, my smaller number of patients exposed to other oral SERDs in the metastatic setting at this point, it's a similar experience. So I've had the privilege of using Elacestrant or Imlunestrant in the metastatic setting, and those patients do well too. I will say there's some more nausea with some agents than others.
Yeah.
But the truth is these are great drugs to use and certainly better than getting bilateral intramuscular gluteal injections.
Absolutely.
frequently.
I don't think we will be sad when the Fulvestrant days
No.
go away.
My patients coming through the door of the clinic, people always know it's one of my patients or one of our breast patients because they'll have ice packs tucked into their pants.
Right. Right.
Yeah.
And actually, I mean, that's a tangible benefit of being able to manage,
It is.
you know, manage with a dual oral regimen for a longer period of
Yeah.
time without the need for infusion, without, you know, having to stop to say, I was planning to travel on X date, but my
Well, that's-
Faslodex injection is due.
Right. The working patient, the mom, anybody who has anything. Right.
Yeah.
All of that
Any
true. Yeah.
responsibilities,
All of
whatever they
that
are.
true.
And it's so funny to me as we think so much about our core tenets of oncology of, yes, lengthening life, but really improving life.
Yeah.
Most of our conversation has really been about improving the quality of life and allowing our patients to have an easier experience, a more meaningful experience with less disease-related complications.
For sure. There's a quote, I think it was Atul Gawande who said, you know, everybody has goals and those goals change. So you have to keep asking the patient. Because when patients are first diagnosed with metastatic disease, I find, there are exceptions to this, but most of them will talk about length of life. I want to be here for this. I want to see this. Keep me alive so I can see these events in my family. And some up front are already focused more on quality of life. But what I see is as time and years go by, quality of life becomes more important than length of life to many of our patients, which is why this trial, I think, is very relevant to that experience.
Yeah, absolutely. And I hope we're succeeding on both fronts with this strategy.
I certainly think we
Yeah.
will.
Yeah.